The Normalising Birth Programme was launched in April of this year, and its main focus is to promote normal birth across the South East Coast region, which involves Kent, Surrey and Sussex. By doing that, the view was that hopefully caesarean section rates would then be reduced, as they've been increasing over the past few years with no evidence that the outcomes have been improved. The programme to date has been a big challenge, but it's been very exciting to have two health professional groups working collaboratively together in order to come up with new ideas, innovative ideas, and share best practice and experience, and really dig deeper and find out the reasons why women are having caesarean sections. We are working with an expert team from the NHS Institute of Innovation and Improvement, who are also working with maternity services up and down the country on similar programmes and projects, although our project is the biggest in the country. To date, we have compiled a database with all women who have delivered in the South East Coast, and we have 26,000 women on that database. And we are using that information to determine which group of women contribute to the overall caesarean section rate. And our key focus for the programme is looking at women in their first pregnancy and labour and women who've had a previous caesarean section. And it's helping services understand the work that they need to do, or which group they really need to focus on. We're also working on key projects like the birth environment in high-risk labour wards to make it more conducive to women being able to labour normally. At the start of the programme, our caesarean section rate was about 26% across the region, and we're aiming to try and achieve 23% by the end of this financial year, which is March 2011. And each maternity service is working really hard to contribute to achieving that result. But also, I think the most exciting thing is being able to work together collectively to deal and tackle with some of the issues that are common across all maternity services.
So the main thing we want to talk about is how the data was useful to the programme.
Yeah.
So I think the most important thing to say up front is this is the first time we've been able to use data to inform a programme of this size. And not only that, nobody's able to hide behind the lack of information about what they're doing. And one of the most important things we're able to do up front, because of the integrity of the data that we've got, is no one's able to suspect that the data isn't realistic and doesn't reflect what we're doing in clinical practice. So for all those reasons, it acts as a very good anchor for what we hang various initiatives around about changing clinical practice. And being able to look at data not in an overall way, so looking at blunt caesarean section rates, but being able to drill into it and actually look at data in meaningful clinical subgroups. And that's the first time we've been able to have that sort of versatility within a data set, which is truly representative. And you're able to compare between units, but most importantly of all, whatever we've asked you to do, you've done. So there's been a we can do it rather than no way can we do it, which is a very fresh and unusual thing to see.
The data has been very important for us because we have two maternity units with very different caesarean section rates. We have not been able to identify exactly what it is that is different between the two units. Using the Robson groups and having the data sent back has allowed us to realise that it is in one particular area where the caesarean rate differs between the two units. What that's going to allow us to do is to focus on the care of women in their first pregnancy, and in particular the induction and augmentation of those women. Although we work to the same guidelines, it's the processes that are actually different. There are different things going on, and it's going to allow us to drill down and to actually make an improvement in that area.